because I gotta be honest with you, I don't think you got what it takes.
Ooh, JD, that is a low blow. Hi, my name's Ed, I'm a junior doctor in the UK, and today we're going to be taking a look at another classic Scrubs episode, this one season 1 episode 17, My Student. Now I went with this one as I've been a teaching fellow for the last few years, so that's a doctor who guides students on their placements in hospital.
You've arrived, you know? You just start to feel, I'm open. Cooler.
That jump shot. Has anyone been listening to the Fake Doctors Real Friends podcast? It is brilliant, and they talk about this intro. This is the longest ONER in the show, so that's a scene that is done in one take, and it's an epic scene. So they go from outside to in the hallway to upper lift, even with this jump shot at the beginning, which the creator of the show, Bill Lawrence, said, no exaggeration, took 70 takes. Bill Lawrence, also a big fan of this channel. Cheers, Bill. Anyone who hasn't listened to the podcast, it's absolutely hilarious and makes me appreciate Scrubs even more.
Let's face it, we've earned the right to be a little cocky.
Absolutely. I still see it in the students that I've been teaching. So once they go from being a student to being a doctor, and when you first meet them, they're quite timid and very shy and just lacking a bit of confidence, which is a good thing when you're a medical student. Shows you a little bit more conscientious, but then you really see their personalities come out, you know, when they build a bit more confidence.
Get our very own med students. Welcome to hell.
Welcome to hell. It's not that bad. Being on the ward at first feels like, not quite hell, but like a space station. You're not quite sure what you're allowed to touch, what you're not allowed to touch, what alarms you're supposed to run towards, what alarms you're supposed to run away, and just the fear of actually speaking to a patient. You feel like the spotlight is on you the whole time, and it's only when you've been on the wards that you start to settle in that you realise the spotlight is on the patient, and that helps to settle the nerves. And the environment goes from feeling like this weird space station where nothing is familiar to much more kind of like your living room.
Now, I want to encourage you all to think of me as your safety net, because I promise you, we're a family here.
Okay, that's a bit awkward for me, because that is very similar to the speech that I give the students when they start. So kind of a little bit too close to the bone for me, but I really do mean it. When people come on placement with us, it's about helping them to adapt to life on the wards as much as teaching them knowledge and skills. Don't forget, this is the first time that many students have lived away from home. So when you go on these hospital placements, you're often staying in the hospital, so an unfamiliar environment. And although lots of people enjoy that independence, for many it disconnects them from their support network, and there can be a fair degree of mixed emotions and, you know, some loneliness.
Listen, nurse. I'm looking for a Dr. Elliot Reed.
I'm Elliot Reed.
Guy's name, guy's job, guy's clothes. Is there anything else you want to tell me?
I was hoping this was one of the Scrubs fantasies, because that is ridiculous. And believe it or not wholly unrealistic. The classic stereotype is probably true that most people are not confident and very self-conscious, but these are the students, as I said earlier, that we don't worry about because their conscientiousness isn't really going to get them in trouble. But these are the students that you worry about, not just on placement, but for the rest of their career in medicine.
Let me tell you what I expect from you. You parted your hair on the other side, didn't you? Okay, so you're going to do H&Ps, you're going to write admission orders.
Okay, H&Ps, so that's doctor speak for history and physical examination. We don't really use that phrase in the UK. More commonly, we'd say a full history and examination. There isn't really a short way of saying it. Maybe that's why US doctors get things done quicker than us.
What are you doing?
Oh, I can't really walk and ride at the same time. It makes me nauseous.
This is an essential skill for any new doctor. Not so much on medical ward rounds, but surgical ward rounds are like watching a factory line. You have to review all the patients with the consultant and make a plan before the start of the first case in theatre. So you just glide through, sometimes having to write really contorted in the corner of one of the rooms. And whilst one of you is documenting, one of you is updating the drug chart and reading out the basic observations, and ideally another doctor is preparing the notes for the next patient to be seen. And you just go on and on and on and see every single surgical patient. And so slow writing like this guy here, oh my word, it would cause so much aggro.
A famous doctor once said, "Show me a med student that only triples my work and I'll kiss his feet."
You kind of have to agree with that. It does take time and energy to have someone shadow you and for you to give them good training opportunities while you're trying to work as well. I always find I am slower and more tired at the end of a shift when I have a student with me. Although you do occasionally get a student who is just absolutely amazing and really helps out. Usually they've worked in healthcare before and they're able to assist with like moving the patient or taking bloods or writing in the notes. And when that happens, it is so good. Regardless, it is super important to give students a chance to learn. Otherwise, how else are they going to do it? We're going to be needing them in the future and we need to set a good example. And as much as it is challenging, it is also extremely rewarding.
Philip, I'm going to need you to shave this patient's groin so I can place a femoral triple lumen.
Yeah, I'm not so much with the shaving a guy's curly.
So a femoral triple lumen, that is exactly what it sounds like. It's an IV access, so a tube going into the femoral vein in the groin, and the tube's pretty long. It actually travels all the way up into the inferior vena cava in the abdomen. Usually we actually use the jugular or subclavian veins for central venous access, as the femoral veins limit your mobility and have a higher risk of infection and blood clots. So shaving of the area here is super important to reduce the chance of that infection risk, but also to help the dressing stick. And the triple lumen bit, as you can guess, means it has 3 lumens, so 3 separate tubes, enabling you to do multiple infusions and to take blood from the line too.
Okay, so I'm gonna need you to change the dressing on the fem-bypass and 402 and DC the staples on the gastroplasty and post-op.
Yeah, I have no idea what you just said.
I'm guessing you might not have an idea on what he's just said. Let's try and break it down. Changing the dressing on a fem-bypass, we're talking about vascular surgery here. We mentioned the femoral vein before, now we're talking about the femoral artery, which is just lateral to the vein, so just on the outside of it, and you can feel the pulse in your groin. The femoral artery is the main blood supply to your leg. And like any artery, it can get blocked, typically with atherosclerosis, so fatty deposits within the blood vessel wall associated with smoking, high blood pressure, diabetes and poor diet. So a fem bypass or a femoral popliteal bypass is where part of that femoral artery is critically narrow, so there's not enough blood supply going to the leg. So we literally do a bypass. So surgery on the leg where we open up the thigh and graft a blood vessel to go around the blockage, hence it's called a bypass. So Turk wants the student to change the dressing over this recent procedure. And what was the other one?
And DC the staples on the gastroplasty and post-op.
So DC the staples on the gastroplasty in post-op. I actually don't quite know what that means. DC the staples, that's the confusing bit. But what we do know is when he talks about post-op, so the patient is post-operation, so they've just had a surgery. What surgery is that? Well, it's a gastroplasty. So gastro means stomach and plasty means to change the shape of. So this is a form of weight loss surgery to make the stomach smaller, similar to a gastric band. But DC the staples, I don't really know what that means. I do often see the term DC meaning discharge, so a patient being discharged from hospital, but doesn't really fit in that context. And this is why Turk's surprised that the student didn't know exactly what he just said shouldn't be met with such judgment, you know? We're all learning.
Josh, what are you doing? I asked you to get this guy's history like an hour ago. It should have taken 5 minutes.
And now we have JD being a little bit harsh here. Taking a history of 5 minutes, that is pretty darn quick. In an exam setting, we very often have to take very focused histories in 5 minutes. But in a hospital setting like this, where you don't want to miss anything, it can take 15, 20 minutes, sometimes even longer to get the full history that you need. And other things can impact as well. The patient may be hard of hearing, have learning difficulties, or need an interpreter. But it certainly is a skill as well to know exactly what questions you need to ask for each presentation. So that massively speeds you up with experience, but also learning how to control a consultation. So often patients don't know what details are significant enough, and so it's your job to try and, get that out of the patient without going over every single insignificant detail.
It's taken 5 minutes.
Oh, yeah, we were just talking. This guy, he is the bomb.
Okay. Bye. Moving on. See you later. Help someone else.
Yeah, don't play drums on a patient. That's JD controlling the situation.
Relax, Bambi. Be nice to Thumper.
He wrote down the guy's sweats when he exercises.
I do.
I'll call Ripley's.
Relax. It's just one mistake. Relax, Bambi. It's just one mistake.
What is that there? That's a blood culture bottle. What has he supposedly have done with that? Drank it? I always thought it looks a lot like a bottle of soy sauce. On this note though, we all do make mistakes, particularly as a student and in your junior years as a doctor.
Miss O'Brien, I'm afraid I'm gonna need a urine sample.
Yeah, as calm and professional as us doctors like to be, we sometimes have our moments.
I only got home 20 minutes ago because I spent the entire night cleaning up after you.
I'm sorry. I was just really scared.
Well, you know what, Josh? You should be scared. Because I gotta be honest with you, I don't think you got what it takes.
Ooh, JD, that is a low blow. It can be so easy to think that, but you have to realize that every single Dr. Cox you see was once a medical student like Josh.
Oh, Nurse Roberts, have you seen Josh?
The tall, skinny one? He quit.
Nice job, Bambi.
Oh, see, this is what happens, JD, when you're mean to people. These are such defining moments for people that are going to stick in their mind, and everyone has imposter syndrome, thinking they're not good enough. So you take this criticism very strongly. In reality, JD would probably get an earful by the university for treating a student on their first few days like this.
This is completely crazy.
You told me I shouldn't be a doctor.
Kidding.
That's the best way to deal with it. Pretend it was a joke. I think JD has worked out the error of his ways now. And this is realistic too. You very often say things in the heat of the moment to colleagues that you really don't mean, and yeah, you have to, as JD's done here, take it to one side and just be straight and honest with them. Medicine is also a bit of a pressure cooker, and I can understand that JD, as much as he was disappointed in Josh, was also disappointed for the patient. Very often we end up fighting each other, but actually it's because we all want the best for the patients and we're in this kind of pressure cooker situation.
Hi. I know we're not supposed to be seeing each other, but,
Ooh. So, dating a medical student, there's probably no law against it, but yeah, you can't do it. The hospital and university would definitely have something to say about it. It is far from the high ethical standards that are expected of you as a doctor.
Why did you page me? I don't even know why I still have this stupid thing on.
Put your gloves on, Josh. I need you to get an ABG.
I can't.
Newbie, wait.
Newbie?
Shut up.
Dr. Cox, JD goes full on Dr. Cox, even convinced me for a minute there. He set a task for Josh to get an ABG, a particularly challenging blood test and one we do quite regularly. It stands for an arterial blood gas, and this is a blood test from an artery, usually the radial artery in the wrist. And by taking from an artery, we get the readings of the oxygen and carbon dioxide gases in the blood, hence the term arterial blood gas. What makes this more challenging is that usually we take blood from a vein. These are close to the surface of the skin. We can see them, we can feel them. It's easy to guide the needle in. However, arteries are deeper in the body, so it takes a little bit more practice to feel the pulse and then guide the needle into it to obtain the sample.
Now, locate the radial pulse. Josh, look at me. You can do this.
It looks good.
No, that doesn't look good. He palpates the radial artery in the right place, but then goes into the side of the wrist like he's going to take blood from the radius, the bone there. There's no blood in the radius. He's made it way more complicated. He just needs to go straight in to the radial artery where he can feel the pulse at its maximal point.
Could you redo that?
Yeah.
I knew it was gonna crack.
I think a lot of us get freaked out when med students come because it feels like being forced to accept new people into your family. It changes everything. Me, I was more struck by how these newbies made me look at myself. Who I used to be. Who I am now. And who I might someday become.
Too bloomin' right. Scrubs, again, they absolutely smash these reflections on working in healthcare. And this is exactly it. You become a doctor before you really know it. And then you look back at the students and you see how far you've come. And then you look at the consultants and you see how far you've got to go. And yeah, perfectly summarized here. So there you have it, my reactions and breakdown and reflections on this episode. As always, it was so good. I never really appreciated Scrubs enough before I studied medicine, but now I've done it, looking back at these episodes, it is absolutely bang on. The writing, the acting, the themes they do, they smashed it. So if you want a bit more Scrubs content, then I definitely recommend checking out the podcast, Fake Doctors, Real Friends, and they really show that they are a proper family behind the scenes, how much love there was on the set, and you can really see it, can't you? But what I also like is they talk a lot about how it was made, and you learn a lot about the industry, actually. That's what I've been enjoying. And so I hope I was able to add a little bit more to this episode too. And so on that note, thank you again for watching and for all the continued support on the channel. I hope you're all well, and I'll be back soon.